Hi guys, today we're going to talk about the use of immunosuppressants. Immunosuppressants are exactly what they sound like, drugs that suppress the immune system, specifically the adaptive or specific part of our immune system. When we use immunosuppressants, we can use them to prevent rejection when we've done some sort of a transplant. So this could be like solid organ transplant or a transplant of bone marrow, for example. We can use immunosuppressants to treat autoimmune disorders. So this would be things like RA, rheumatoid arthritis, or lupus, where the patient's immune system is attacking their own body. So the way to decrease symptoms in that case is to decrease the patient's immune response. There are some various other diseases where we can also use immunosuppressants. These are typically diseases that involve a lot of inflammation, but we'll mention them as we go. There are a few kind of key principles of therapy when we're using immunosuppressants that I want to mention first. And I want to take a look at the immune system and immune activation so that we can see all of the various places where immunosuppressants can work. Principles of therapy with immunosuppression. First off, with the new agents, with modern immunosuppressive therapy, we target therapy towards suppressing cell-mediated immunity. The older immunosuppressants were non-selective, and they targeted both the humoral arm of immunity and cell-mediated immunity. Remember, when we talk about specific immunity or adaptive immunity, there are two key arms. There's humoral immunity, which involves B cells going on to turn into plasma cells and eventually producing antibodies. And then the other arm is the cell-mediated immunity arm, and this is the arm that involves T cells. So, cytotoxic T cells directly attacking the invader, helper T cells stimulating the whole immune response. So older immunosuppressants were not selective for just cell-mediated immunity. They targeted both arms. So because of this, they completely wiped out the patient's immune system. They had absolutely no defense against infection at all. So unfortunately, we did see a lot of patients dying from infection. Mortality rates were unacceptably high because of infection. Now, the newer agents target cell-mediated immunity, and this leaves the other aspects of the immune system intact. So the patient, still does have some defense against infection. Most drugs that we see used now are either antibodies or drugs that target immune system proteins, but we'll talk about that in a minute. When we look at the immunosuppressants, drugs can be classified by their mechanism of action or by their place in therapy. For example, if we're talking about prevention of rejection, right? If we're going to do an organ transplant or bone marrow transplant and we want to prevent rejection, we have two kind of stages of therapy: induction therapy and then maintenance therapy. We can classify drugs based on whether they are induction drugs or maintenance drugs. Drugs that are used for induction are typically the most potent agents. When we first transplant an organ, when we go into induction therapy first, we kind of hit it really, really hard. And then once we've done that, we can go into maintenance therapy. Maintenance therapy is typically accomplished with less potent drugs at lower doses, for long term. So we can classify drugs, as, again, induction agents or maintenance agents, or we can classify drugs based on their mechanism of action. Also, when we're using immunosuppressants or giving immunosuppressive therapy, typically we use multiple drugs at low doses. Again, 2 to 4 agents, as opposed to using just one drug. These drugs can be associated with severe toxicities when used as monotherapy. If we give just one drug, we have to give that drug at a high dose. And then, the drug is associated with a lot more toxicities. In order to minimize toxicity, we can give multiple drugs that are affecting, different parts of immune activation. And we can give those drugs at lower doses, and that allows us to minimize toxicity. One thing that is important, again, here you see these drugs should have different mechanisms of action. So, for example, we're affecting T cells, right? We're affecting cell-mediated immunity, which is T cell activation. So there are numerous steps that are involved with T cell activation and the T cell response. So if we use, say 3 drugs that are preventing T cell activation in different ways, we can use those drugs at lower doses and again, minimize toxicities. But it is important to choose drugs that have a different mechanism of action. Here we see immune system activation, which is a really complicated process. I'm not worried about you recreating every step of this process, but I do want you to realize that there are a few different steps that are required for activation of the T cell. And because this is such a complicated process with so many steps, this does give us multiple different places where drugs can work. And this is why we're able to choose 2 to 4 drugs that have different mechanisms of action and affect a different part of this process. So immune activation occurs in what we call the 3-signal model. And here you can see, the 3 steps or 3 signals that are required for activation of the T cell and, eventually T cell proliferation, which is, what ends up happening when we activate the T cell. Here you can see the 3 signals marked, signal 1, signal 2, and signal 3. Signal 1 and signal 2 over here are where the antigen presenting cell is presenting the antigen to the T cell. And remember, that antigen presentation is required for the T cell to be able to recognize the antigen. It can't just recognize antigens and get activated on its own. It has to have this, presentation of the antigen. So here you can see the antigen presenting cell presenting the antigen, and there are 2 binding sites that are required. We call this co-stimulation. There are 2 binding sites that are required between the antigen presenting cell and the T cell. So signal 1 is showing us where the T cell is triggered by this antigen presenting cell and T cell receptor complex, where again it's just the antigen itself being shown to this T cell receptor. That alone can't cause T cell activation. Again, we need this co-stimulation. So that's where signal 2 comes in. At signal 2, we have the CD80 and CD86 on the antigen presenting cell are binding to CD28 on the T cell. Again, I'm not worried about you knowing these receptor names or anything like that, but just know, there's a second binding site between the antigen presenting cell and the T cell. So co-stimulation is required. We've got to present the antigen, and we need this second binding to occur in order to activate this T cell. So both of those signals together result in activation of multiple intracellular pathways. And that's kind of, what you see happening here inside the cell. But we have, multiple intracellular pathways, one of which is what we call the calcium-calcineurin pathway. We end up having increased intracellular calcium, and that activates calcineurin. So that's what you see right here. Calcineurin is an enzyme that activates something called NFAT. NFAT. NFAT then enters into the nucleus, and that activates the genes for various different cytokines, right? So this is, we see calcineurin. Here you can see coming in, activating NFAT, coming into the nucleus, and then producing various cytokines. One of those cytokines that's produced is interleukin-2. And interleukin-2 is going to be necessary in this, activating process, in this immune activation. That interleukin-2 is actually related to our kind of third signal. So that interleukin-2 that gets produced, right? We activate the T cells, various reactions occur, one of which allows us to produce interleukin-2. Right here you see the mRNA leaving, we produce interleukin-2, interleukin-2 gets released. That interleukin-2 binds to receptors on other T cells. It's CD25, but again, that doesn't matter. The interleukin-2 binds to receptors on other T cells, which begins this signal 3 pathway. Signal 3 involves activation of something called mTOR, mTOR. It stands for mammalian target of rapamycin. But once interleukin-2 binds to its receptor and we activate mTOR, what that does is that causes cell division in the T cell. So cell division, proliferation of T cells. This triggers the T cell to, in its life cycle, to go into the actual mitosis process where it can divide. So you can kind of see there's a whole lot involved here. First we just activate this T cell by presenting the antigen to it. Then that allows us to produce chemicals that are going to go and activate or tell all of the other various T cells to start proliferating and dividing. Kind of key places here, key things here. Obviously binding is important. This activation of calcineurin is important. This activation of mTOR is important as well. And you can kind of see all the little red minus signs are showing you places where we can, have drugs that can work or can kind of inhibit this process. This is a chart of various different drugs that are used for rejection, either induction or treatment of rejection or maintenance therapy. I'm not going to spend a lot of time going through this chart because we are going to talk about the drugs individually, but this is kind of a nice place to have all of the information to come back to. You can see you've got the drug, the class. Most of these are some sort of antibody, so monoclonal antibodies, polyclonal antibodies, immunoglobulin, which is an antibody. Corticosteroids are the kind of standout here. They're a little bit different. You can also see the mechanism of action and the indication. Most of these are used for induction or treatment of rejection. You can see that for methylprednisolone, the corticosteroid, we also have maintenance therapy as well. So we're going to talk about the drugs that can be used for induction, which remember is the initial phase of anti-rejection therapy that we use when we're doing some sort of an organ transplant, and rejection therapy. So, drugs that would be used if a patient is actually experiencing rejection after organ transplant. First, we're going to talk about anti-thymocyte globulins. Thymocyte, like T cells, right? Thymus-dependent cells. So anti-thymocyte globulins are polyclonal antibodies that can come from either rabbits or horses that have been immunized with human thymocytes. So just like immunizations work in us, right? You inject part of an antigen and the person has a stimulated immune response against that antigen. So we put, thymocytes, human thymocytes in the rabbit or the horse, and the animal's immune system, attacks those thymocytes. And part of that process is producing antibodies against thymocytes. And then we can take those antibodies from the rabbit or from the horse, and we can then use them as medication to fight human T cells. So like the mechanism of action here would be, we have antibodies that we give, polyclonal antibodies that we give, that fight or attack human T cells. So this ends up causing T cell depletion. So any T cells that, are being, that are present or would be activated or produced will be attacked. Notice I've bolded and kind of starred rabbits. The rabbit preparations are preferred because they tend to have greater potency and are associated with lower toxicity. So the rabbit anti-thymocyte globulins would be preferred over the horse. The primary use of anti-thymocyte globulin is for induction therapy. So, primarily we would use this at the time of transplant to prevent early rejection. Again, I'll write induction. Again, we would combine this with other agents. We wouldn't use it as monotherapy. It can also be used to treat severe rejection or corticosteroid resistant rejection, acute rejection. When we look at using the anti-thymocyte globulins, they are administered via IV infusion for 3 to 10 days. But they produce profound lymphopenia that can last over a year. So even though we're giving it just for a short period of time, this can produce lasting effects. Again, lymphopenia, penia means poverty. So lymphopenia is a poverty of lymphocytes. So decreased lymphocytes for, over a year. When we look at, adverse drug effects or kind of cautions related to the anti-thymocyte globulins, they are associated with infusion-related reactions. So this is typically like flu-like syndrome or flu-like symptoms, so chills, fever, body aches. So in order to decrease these or try and prevent these, we do pre-medicate. So before administering each infusion, we give patients corticosteroids, so like prednisone, for example, acetaminophen, which is just Tylenol. That would be to prevent the fever, and then some sort of antihistamine. Prolonged use of the anti-thymocyte globulin can really cause profound immunosuppression. And this profound immunosuppression can really make the patient susceptible to opportunistic infections. So opportunistic infections like CMV, or what we call post-transplant lymphoproliferative disease. Post-transplant lymphoproliferative disease. And I will talk about that more a little bit later. It can also be associated with some pulmonary edema. So these are all things to look out for. One thing, just kind of note as we go through these, you'll hear the words, polyclonal antibody or monoclonal antibodies. Poly means, many, right? Mono means one. So these are polyclonal antibodies. They are kind of more variable or less specific than the monoclonal antibodies. So we can see kind of more adverse effects with them. However, they are very inexpensive to produce. They're very, very cheap to produce. The monoclonal antibodies are more expensive to produce, but they are more selective in their effects. We'll talk about basiliximab. Just kind of in general as a little tool, the drugs that end in mab are monoclonal antibodies. That's what the MAB stands for, monoclonal antibody. So basiliximab is a monoclonal antibody that binds to the interleukin-2 receptor on activated T cells. Remember, monoclonal antibodies are a little bit more targeted and specific in their actions. So basiliximab is used for prophylaxis of acute rejection in renal transplant. It's used along with cyclosporin and corticosteroids. Note, we are saying prophylaxis of acute rejection. It is just used for induction therapy to prevent rejection. It is not used in the treatment of rejection. And let's just look at the way that it works, and this will kind of explain why. So it binds to the interleukin-2 receptor on activated T cells. The interleukin-2 receptor, that's the CD25, that's where the T cell gets stimulated to proliferate, right? Remember, when we first activate the T cells, they end up producing interleukin-2, and that interleukin-2 is released. It goes and it binds to the interleukin receptor on T cells, and that's what actually tells them to start dividing, right? To divide to build up this army of T cells. So if you block interleukin-2 receptor, right? If you block the CD25, then the T cell is not told to divide, right? You never have that proliferation of T cells. So you prevent the ability to elicit this T cell response. Hence, the fact it's preventing rejection. The reason it would not be used to treat rejection is because if rejection is occurring, the T cells have already proliferated, right? You already have all of these T cells that are attacking the transplant. So it wouldn't do any good to prevent proliferation because proliferation has already occurred. In that case, you need something that is T cell depleting, right? You need something that goes in and gets rid of the T cells that already exist if you're trying to treat rejection, just like we saw on the last slide. So again, used for prophylaxis of rejection in renal transplant. When we use the basiliximab in renal transplant, this postpones the need for a calcineurin inhibitor. and allows for lower doses of a calcineurin inhibitor once you need to start one. This is very beneficial in renal transplant because calcineurin inhibitors can be associated with some renal toxicity. Typically the patient's going to need to be on a calcineurin inhibitor. But again, the calcineurin inhibitor causes renal toxicity. So if you've just given the patient new kidneys, you don't want to be giving them a drug that is cleared by the kidneys or can cause some kidney damage until the new kidneys are there, they're kind of settled in, if you will, they're working appropriately, etc. So like this is really helpful in patients with delayed graft function. So if you've transplanted kidneys, but the kidneys aren't working yet, you can't give them something that's cleared renally or renally toxic, etc. So you can give them this basiliximab for induction therapy. And again, you don't have to give the calcineurin inhibitor until later. And when you give the calcineurin inhibitor, you can give it at a lower dose, which decreases toxicity to these new kidneys that we've just given the patient. Basiliximab is administered via 2 IV infusions. These IV infusions are given, the first one is given 2 hours before transplant, and the second one is given 4 days after transplant. Basiliximab is well tolerated. Again, monoclonal antibodies do tend to be better tolerated than polyclonal antibodies because of their selectivity. Alemtuzumab is again MAB, so monoclonal antibody. This is a monoclonal antibody that binds to CD52 on both T cells and B cells. So this actually affects both cell lines. It rapidly depletes both lymphoid cell lines. So it depletes, gets rid of T cells and B cells. The T cells can take about 6 to 12 months to recover, like before you have good numbers of T cells back again. B cells take typically up to about 6 months to recover. So both cell lines are depleted for at least 6 months. This can be used for the treatment of chronic lymphocytic leukemia. It can also be used for relapsing multiple sclerosis. It can be used off-label as well for aplastic anemia. As far as rejection goes, it can be used for induction therapy, and it can also be used to treat rejection because it does deplete cell lines. It can be used for treatment of really either acute cellular rejection or antibody-mediated rejection. So for rejection, it can be used to treat both cellular rejection and it can be used for antibody-mediated rejection. Because again, it does affect both T cells and B cells. The other agents that we've talked about thus far are, affecting T cells. Just kind of caution, alemtuzumab has or causes very potent immunosuppression, and it is prolonged immunosuppression. Again, we have 6 months where we've depleted T cells and B cells, and T cell depression lasts even longer than that. And this is potent suppression. So patients do need to receive prophylaxis for pneumocystis pneumonia and herpes. before or while getting the alemtuzumab. No, this is not available on the general market. So it's not like, every hospital just has alemtuzumab and they give it to patients whenever. It's not available in the general market. You can only get it from what's called CAMPATH distribution. So there's like a specific, application process and paperwork that has to be filed in order for you to be able to use this for your patient. And essentially, you've got to show that there's not something else that you can use, that this has to be used for some specific reason. Next, we'll talk about rituximab. Again, MAB. So this is a monoclonal antibody. Rituximab is a bit more versatile than the other agents we've talked about thus far. It is used for, prevention of rejection or treatment of rejection, but it's also used in various other diseases as well. So rituximab is a monoclonal antibody that binds to CD20 on B cells. So this ultimately ends up preventing activation of B cells, and it causes lysis of B cells. So it kills B cells and prevents their activation. And this binds to all different types of B cells. So like pre-B cells, mature B cells, memory B cells, ultimately causing B cell depletion. And because this prevents B cell activation, B cells don't mature into plasma cells that would produce antibodies. So it prevents that kind of antibody formation. This depletion of B cells lasts about 9 to 12 months. So it's pretty prolonged depletion of B cells. Note, it doesn't bind to plasma cells. So there is a kind of short period of time for it to kind of have a full effect because plasma cells that are already formed are still able to produce antibodies, but it does prevent any further production of more plasma cells and further production of antibodies down the line. Use of rituximab can be used in B-cell lymphoma. We see it in both Hodgkin's and non-Hodgkin's lymphoma. It can be used in RA, rheumatoid arthritis. We do also see it used in lupus. A lot of places. We can see it used in myasthenia gravis. Various other conditions. As far as transplant goes, it can be used for post-transplant lymphoproliferative disease. It can be used to treat antibody-mediated rejection. Note, it is only used in antibody-mediated rejection. It is not used to treat acute cellular rejection because it does not affect T cells. So if the patient's experiencing acute cellular rejection, you're going to have to treat it with a different immunosuppressant. Rituximab would not do any good in that case. Rituximab is administered typically via an IV infusion. The IV infusion is typically given over like 4 hours. The first infusion is recommended to be given slowly to decrease infusion reactions. I'll talk to you a little bit about that in a second, though. There is a newer subcutaneous infusion. This subcutaneous version, it's just formulated a little bit differently to help with permeation. But the subcutaneous version is given via subcutaneous infusion over the course of 5 minutes. So that's a lot easier to give. The only thing is, in order to give the subcutaneous version, patients have to have had one dose via IV infusion. So at least the first dose that they get has to be via IV infusion. And then after that, it's possible to give the subcutaneous version, which again, 5 minutes is a lot easier than sitting there for, like a 4-hour infusion. Also, subcutaneous is a lot, is preferable to IV. Cautions, infusion reactions are very, very common. Infusion reactions happen in over 50% of patients. They are more likely on the first dose. Hence the fact that the first dose is typically given very slowly. Infusion reactions include just flu-like symptoms, so fever, chills, headache is very common as well. And these symptoms typically stop when the infusion stops. So it's not this really long-lasting thing, but it can be very annoying and uncomfortable for the patient while they're getting the infusion. In order to decrease the severity and likelihood of these, we do pre-medicate. The recommendation from UpToDate is that we give 650 milligrams of Tylenol or acetaminophen. APAP is the abbreviation for acetaminophen or Tylenol. And then 50 milligrams of diphenhydramine, that's just Benadryl. It's an antihistamine. So pre-medicate with acetaminophen and diphenhydramine, and then the first infusion needs to be given very slowly, and then it starts out very slow, and then the speed can be increased every 30 minutes. Again, given over 4 hours. So giving it slowly, especially that first time, decreases the likelihood and severity of infusion reactions. Mucocutaneous reactions are also possible. Muco, like mucous membrane, cutaneous, like skin. So this is things like TEN, toxic epidermal necrolysis, or SJS, Stevens-Johnson syndrome. These are also possible. There's also the possibility of reactivation of various different viruses. So what this means is if the patient had the virus in the past, and you treated it, or the patient has made it past that virus, they're no longer impacted by the virus, there's a possibility that there can be a reactivation of the virus, and the patient can, become acutely ill again. There's a black box warning for reactivation of JC virus. JC stands for John Cunningham. This JC virus attacks the white matter of the brain, and it can lead to leukoencephalopathy. So it is important to check serology to see if the patient has had JC virus in the past. Also, we can have reactivation of hepatitis B or CMV, cytomegalovirus, CMV. So we do a couple things. We monitor hepatitis serology. So we do check patients to see if they've had hepatitis B in the past. And we do monitor for reactivation of that. There are various recommendations as far as prophylaxis goes. For example, patients with CLL, chronic lymphocytic leukemia, because remember, this rituximab can be used for various things. It's not just rejection. It can be used for various types of cancer. It can be used for RA, for lupus, myasthenia gravis, etc. So patients with CLL, it's recommended that they get prophylaxis for viral hepatitis and for pneumocystis jirovecii pneumonia. So CLL patients should get viral hepatitis and pneumocystis, Jirovecii pneumonia prophylaxis for 12 months. The recommendation, so the CLL patients, is recommended that they get these. All patients who have resolved hepatitis B infection and are taking rituximab should also get, or it's recommended that you should consider viral hepatitis prophylaxis. Okay, so CLL patients, this is the recommendation. All other patients taking rituximab, if they have resolved hepatitis B infection, you need to consider giving them hepatitis prophylaxis, okay, viral hepatitis prophylaxis. Now this cancer patients, non-cancer patients, it doesn't matter. Okay, so again, first step is going to be to check, to see if they've had hepatitis B or not. And then you can, consider whether you need to give prophylaxis. Bortezomib is a little bit different than the other agents we've talked about thus far. Bortezomib is a proteasome inhibitor that causes depletion of plasma cells. So this is also working on, antibodies, on the antibody B cell type line, but this is kind of working in a different place than what we were just looking at. The rituximab affects B cells, but rituximab does not affect already made plasma cells. So the bortezomib is working in antibody-mediated rejection in a different way. It's decreasing antibody production in already sensitized patients. So the patients already had activation of B cells. B cells have already, matured or differentiated into plasma cells, and those plasma cells are making antibodies. The bortezomib will go in and get rid of those plasma cells that already exist. Bortezomib can be used for multiple myeloma, which is a cancer. It is first line with prednisone and melphalan. Melphalan it's called an alkylating agent. That's an anti-neoplastic agent. So melphalan is used for cancer, and then the bortezomib and prednisone are both immunosuppressants. So again, this is an approved first line therapy or combination to be used for multiple myeloma. However, bortezomib is also being used for AMR, right? Antibody-mediated rejection. Now again, this would not work for acute cellular rejection because it's not affecting T cells. But again, an antibody-mediated rejection, this works on the already sensitized B cells that have already differentiated into plasma cells. Now, this would not work for prevention of rejection or induction therapy because it's working on, the cells that have already been activated. It's not preventing activation. Administration can be via either an IV bolus or it can be given subcutaneously. So we're not talking about like a long infusion. Because of that, there's a very low potential for infusion reactions. Typical adverse drug effects that we do see are nausea, vomiting, diarrhea. It's possible to see some hypotension, some peripheral neuropathy. Bortezomib has been associated with hepatotoxicity, but this is very rare. It's not a common reaction. The immunoglobulin, or we frequently call this IVIG, these are just immunoglobulins from the donor blood from a lot of people. So a whole lot of people have blood that's been donated. You take the various different immunoglobulins that are present in all of these people's blood, and that's given as a combination. IVIG has immunomodulatory effects on both T cells and B cells. It also interferes with the binding of antibodies to the transplanted graft when IVIG is given in high doses. IVIG is kind of versatile. We do see it used in some autoimmune diseases. It can be used in desensitization protocols pre-transplant. It can be used in the treatment of antibody-mediated rejection. We see it used in multiple myeloma pre-stem cell transplant. We also see it used in various different cancers as well. Also, low doses of IVIG can be given to prevent infection this is replacing immunoglobulin that's lost during plasmapheresis. Infusion reactions are typically not severe, but patients can experience headache, fever, chills, myalgias, some blood pressure changes. Again, these are kind of typical infusion reactions. But slowing infusion rate decreases the reaction. These are, infusion reactions, kind of mild infusion reactions are the most common things that we see. Again, slowing the rate decreases those. Rarely we can see some more serious adverse drug effects, including aseptic meningitis. Aseptic is like there's no antigens there, right? There's no pathogen causing the meningitis. It's not viral, it's not bacterial, but we still have meningitis. There's inflammation of the meninges, even though there's not an infection present. We can see some acute renal failure and then thrombotic events. So that's induction therapy or treatment of rejection, either a cell-mediated, acute cell-mediated rejection or antibody-mediated rejection. And then you also saw that the different drugs can be used for various other conditions, some cancers, some autoimmune diseases, etc. Now we're going to talk about maintenance immunosuppressants. So these are the immunosuppressants that we use for a longer period of time to prevent rejection. Maintenance immunosuppressants provide prolonged suppression of rejection while minimizing adverse drug effects. So we're minimizing just the kind of typical adverse drug effects. We're minimizing the likelihood of infection because we've completely wiped out the immune system. And same thing, with cancers, minimizing the likelihood of experiencing some sort of, opportunistic type cancer. When doing maintenance immunosuppression, again, we typically will give multiple drugs, 2 to 4 drugs that each have a different mechanism of action. And the benefit of giving multiple drugs is that we can give them at a lower dose to minimize toxicities. Drugs that we use include calcineurin inhibitors, cyclosporin, and tacrolimus. These agents we mentioned previously when we were talking about renal transplant, but calcineurin inhibitors are used. Co-stimulation blockers, belatacept is the co-stimulation blocker. mTOR inhibitors, that's sirolimus and everolimus. And then finally, we have anti-proliferatives as well, mycophenolate and azathioprine. Here, this is just showing us a chart of all of these agents. Again, I'm not going to go through everything on this chart. This is just kind of nice that it has everything here in one place. We're going to go through each of the drugs individually. So first we'll talk about the calcineurin inhibitors. Calcineurin inhibitors include tacrolimus and cyclosporin. These drugs work, they prevent T cell activation by blocking the calcineurin calcium pathway. Remember in the very beginning of the lecture, we looked at that picture that showed the 3-signal pathway that was necessary for T cells to be activated and to proliferate. This interferes with signal 1 of T cell activation. If you can remember back, the antigen presenting cell presents the antigen, and that first signal involved an increase in calcium and an activation of calcineurin. And then remember that calcineurin goes into the nucleus and ultimately results in the production of interleukin-2. That IL-2 is necessary for T cells to start dividing and to build up this army of T cells. So by blocking this calcineurin calcium pathway, we're preventing T cell activation and T cell proliferation. Calcineurin inhibitors are a mainstay of treatment for various different types of solid organ transplant. So they're used for maintenance immunosuppression in all different types of solid organ transplant. And what we mean by solid organ transplant is, like, for example, kidney transplant, lung transplant, liver transplant. The other type of organ transplant is bone marrow, but this is solid organs. So we use calcineurin inhibitors for various different types. Due to better prevention of rejection, tacrolimus is the preferred calcineurin inhibitor. When we're talking about maintenance, prevention of rejection in solid organ transplant. That's why I have the tacrolimus kind of with an asterisk up there. It is generally preferred. The calcineurin inhibitors can be used off-label in various other autoimmune conditions. So here you see Crohn's, RA, myasthenia gravis, but this is not a first-line treatment. Calcineurin inhibitors in autoimmune conditions are reserved for patients who don't respond to other therapies. And the reason for this is they are associated with some severe adverse drug effects. For example, there are negative effects on the kidney, can be associated with hypertension. We'll talk about all the adverse drug effects in just one second. And there are also newer biologics that can be used in autoimmune conditions that are associated with good efficacy without having as many adverse drug effects. So these are only used in patients who don't respond to the biologics or other therapies that are available when we talk about autoimmune conditions. They are first line in solid organ transplant. When we look at administration of the calcineurin inhibitors, they have very variable absorption. So we monitor drug concentrations when we're figuring out the dosing schedule. Dosing is based off of a 12-hour trough. So what this means is 12 hours after giving the medication, we monitor the serum concentration. And at that point, it should be at its low point, right? That's right before we give another dose. So that's the trough or the lowest concentration. Note that this 12-hour trough is great for tacrolimus when we're giving the immediate release tacrolimus. Tacrolimus does also come in an ER formulation, an extended release formulation that's given once a day. In that case, we would get a 24-hour trough. Because we're giving it once a day, the lowest point is right before we give the next dose, which is after 24 hours. Also, for cyclosporin, the kind of general practice has been to dose it based off of a 12-hour trough. But studies show that that's not actually the best way to dose cyclosporin, and that cyclosporin is better monitored with a 2-hour post-dose level. The 2-hour post-dose level is giving us the like a max level, and this correlates better with toxic exposure as well as rejection prevention. So the 12-hour has been kind of the normal process, but again, like most recent studies show that that's not actually the best way to study cyclosporin, just to kind of have that in the back of your head. With the tacrolimus, though, tacrolimus is generally preferred anyways, and that is dosed off of the 12-hour trough or 24-hour trough for the extended release. Cautions with the calcineurin inhibitors. One kind of big one here is nephrotoxicity. Remember, we talked about this earlier in patients who have kidney transplants, how sometimes that can be a problem, especially if there's delayed graft function. There are some metabolic adverse drug effects. We can see Cushing's syndrome, diabetes, and this includes new onset diabetes. So it's not, just a worsening of diabetes in diabetic patients. We can actually see, patients who have never had any pancreatic problems develop diabetes. Hyperlipidemia as well. There are also various cardiovascular effects, again, including hypertension, hirsutism, which is hair growing in places where it typically does not grow, and then various drug interactions as well. So these are very effective, again, a mainstay of treatment for solid organ transplant, but they are not innocuous drugs. They are associated with a lot of toxicities, hence the need for monitoring and close monitoring of the dose. Belatacept is a co-stimulation blocker. It's actually a second generation co-stimulation blocker. So what it does is belatacept binds to CD80 and ED6 on the antigen presenting cell, and it prevents the T cell from binding. This is the co-stimulation aspect of the antigen presenting cell. Remember, the antigen presenting cell has to bind to the T cell in two places. You have the actual presentation of the antigen, and that's where the signal 1 activation comes from. And then signal 2 of T cell activation is where the antigen presenting cell binds to the T cell in that second place, that co-stimulation receptor. So this prevents that co-stimulation, blocking signal 2 of T cell activation, which ultimately prevents the T cell from being activated and prevents proliferation of T cells. Belatacept is used mainly in kidney transplant. It's typically used in combination with basiliximab, mycophenolate, and corticosteroids. It can also be substituted for calcineurin inhibitors in order to avoid some of the long-term adverse drug effects of calcineurin inhibitors. Again, they are nephrotoxic, which is especially problematic in kidney transplant, and then they are associated with the various metabolic and cardiovascular effects. So, this substituting for that calcineurin inhibitor can be beneficial. Also, the belatacept can be used off-label in heart and lung transplant. And remember, we're talking about maintenance immunosuppression. So, in this case, we're not talking about the way that we would use something for rejection or induction therapy. We're talking about maintenance. There's also a first-generation co-stimulation blocker that's called abatacept. Sorry, I can't write it up there. Abatacept. Again, a co-stimulation blocker, and this is approved for use in RA. rheumatoid arthritis. Belatacept is given intravenously in kind of two phases. Initially, it's given more frequently at a higher dose, and then long-term, it's given intermittently at lower doses. So textbook recommendation is that during the first phase, it's given 4 times in the first month at a higher dose, and then after that, it's given once monthly, and that starting at 4 months, you can give it at a lower dose. Note Up to Date has a newer regimen that recommends 10 milligrams per kilogram, so it's weight-based, on day 1 and day 5. Then you give that 10 milligrams per kilogram at the end of week 2, the end of week 4, the end of week 8, and the end of week 12. Then starting at week 16, the end of week 16, so that's like 4 months, starting at 4 months, you give the patient 5 milligrams per kilogram every 4 weeks. So really the second phase is the same, right? A lower dose, 5 mg per kg, once a month, right? Every 4 weeks, starting at 4 months. It's just the first phase that's a little bit different. When you look at the newest up-to-date recommendation. One thing that is important here, very important with belatacept, it does have an increased risk of causing post-transplant lymphoproliferative disease, and for whatever reason, this predominantly affects the central nervous system. Belatacept actually has a black box warning for causing post-transplant lymphoproliferative disease. Now, there is a higher risk for this in patients who do not have immunity to Epstein-Barr virus. So in patients who have never been exposed, who are seronegative for Epstein-Barr virus, they are more likely to get this post-transplant lymphoproliferative disease. Because of that, patients can only be given belatacept if they have had exposure to Epstein-Barr virus. So you cannot give it to patients who are seronegative for Epstein-Barr virus. The exact quote from the prescribing information is, "Do not use belatacept in transplant patients who are Epstein-Barr virus seronegative or with unknown Epstein-Barr virus serostatus." Okay, so all patients, before you give belatacept, you have to check serology to confirm that they have been exposed to Epstein-Barr virus. If they have not been exposed or you don't know, you cannot give belatacept. Okay, sirolimus and everolimus are mTOR inhibitors. Again, if you think back to the way that T cells are activated, mTOR is involved in signal 3. So by inhibiting mTOR, sirolimus and everolimus prevent signal 3 from completing. Signal 3 was the signal that ultimately causes the T cells to proliferate, right, to start dividing. So by blocking this pathway, these prevent T cell proliferation. These are commonly used in combination regimens post solid organ transplant in order to decrease the dose of the calcineurin inhibitor that's necessary. And again, remember the calcineurin inhibitors are associated with a lot of adverse drug effects. One of the major things that we worry about is nephrotoxicity, or kidney damage. So if you combine the calcineurin inhibitor with sirolimus or everolimus, then you don't need to use as high of a dose and you can decrease the likelihood of kidney toxicity. When we look at administration, these are dosed orally based on trough concentrations. So again, we have serum drug monitoring. Sirolimus is nice, it is dosed once daily. So that would be a 24-hour trough. Everolimus can also be used at higher doses for various cancers. So for example, like breast cancer or renal cancers, because of the anti-proliferative effects. In cancers, we've got a lot of proliferation, so anti-proliferative effects can be used for that case. So various cancers, breast, sorry, my pen's not showing up well, guys, but breast cancer or renal cancers. Sirolimus is kind of interesting. There are sirolimus-coated stents, and the sirolimus, like the anti-proliferative action, prevents restenosis by the endothelial cells. So by preventing overproliferation of endothelial cells, it prevents that stenosis of the vessel and keeps the vessel patent, keeps the vessel open. When using the mTOR inhibitors, caution with drug interactions. There are a lot of viable or important drug interactions. Also, adverse drug effects include hypertension, hyperlipidemia, impaired wound healing, and again, this is because of anti-proliferative effects. There's obviously a lot of cell division or proliferation of cells that occurs when a wound is healing, and stomatitis. Okay, azathioprine and mycophenolate are anti-proliferative agents. They actually have different mechanisms of action. Azathioprine gets converted into something called 6-mercaptopurine, or 6-MP. That 6-MP gets incorporated into the nucleic acid chain, and because it's not the appropriate nucleic acid, it blocks any further elongation of the chain. Mycophenolate inhibits the enzyme that's necessary to make GMP, and GMP is necessary to make nucleic acids. So in both cases, you're unable to make DNA, which is necessary for proliferation of cells. It's just that they do it in different ways. So both azathioprine and mycophenolate prevent the proliferation of both B cells and T cells. The reason I have mycophenolate starred up here with an asterisk is that mycophenolate has largely replaced azathioprine because it's got better safety and efficacy. So when we look at anti-proliferatives, it's more likely that you'll have a regimen that's using the mycophenolate. These are used adjunctively along with a calcineurin inhibitor for post-solid organ transplant. So these would be combined with other agents, including a calcineurin inhibitor, for maintenance immunosuppression after getting some sort of a solid organ transplant. Adverse drug effects include most commonly nausea, vomiting, and diarrhea. Of course, we have suppression of B cells and T cells, and with azathioprine, the dose-limiting side effect is bone marrow suppression. White blood cells do need to be monitored, and that's typically what kind of controls our dose. But again, mycophenolate is going to be used over azathioprine in most cases. The metabolism of azathioprine is inhibited by allopurinol. Allopurinol is an anti-gout agent that should not be combined with azathioprine because you have big increases in concentrations of azathioprine, which again can then cause even more profound bone marrow suppression, which makes the patient susceptible to infection. Corticosteroids are also used for post-transplant immunosuppression and in autoimmune disorders or diseases. Post-transplant, typically we see prednisone and methylprednisolone used, again, always in combination with other agents to prevent acute rejection in solid organ transplant. When we see corticosteroids used for autoimmune diseases. We typically use prednisone or prednisolone, and again, for various different autoimmune conditions, including RA, SLE, lupus, temporal arteritis, asthma. Just for asthma exacerbations, you guys know we don't use corticosteroids long-term in asthma unless it's inhaled corticosteroids. And in this case, we're talking about systemic corticosteroids. Corticosteroids work by reducing lymphocyte populations. T cells are most affected. In general, we do try and use other agents now for maintenance therapy due to the long-term adverse drug effects of corticosteroids. And we do have some other agents that we can use to avoid those long-term side effects. So generally, we just use short courses of corticosteroids when we can. Those adverse drug effects include, the various metabolic effects. They are diabetogenic, so we do see diabetes and increased glucose. They also do increase cholesterol. We can see other systemic effects like weight gain, osteoporosis, cataracts. We see issues with growth in children. We see hypertension. We see suppression of the hypothalamic pituitary axis, immunosuppression, but in this case, that's what we're looking for. So a lot of adverse drug effects. This, guys, the last thing, I just wanted to include a good resource here. This is from Up to Date, and it's got a lot of good information if you've got time to go in and read it. I will do a separate lecture on RA, on rheumatoid arthritis, just to see the way that we can kind of use these specific agents when treating one of these autoimmune diseases.